All right, well, welcome back. This is Cherry again, and we're going to be talking a little bit about behavioral and psychiatric emergencies, which will include suicide. I have to be honest with you, this is one of my very favorite kind of patients to deal with. I think mostly because they present such a challenge, and I think all of us have a desire to be liked, and I think it's just a challenge to see if I can somehow break through their psychic disturbances to see if I can create a relationship with them. It might be a bit of a psychiatric issue on my part as well. But we're going to talk about these people because you are going to see them in your EMS career. So we're going to talk about psychiatric emergencies. We need to probably identify what that is. And as you have read in your textbook, and I know you've all read your textbook, and I'm very proud of you for that. Any patient that presents with unexpected or dangerous behavior can be considered a psychiatric or behavioral emergency. Now, there's lots of reasons that patients may present this way. It can be from something as minimal as stress, although stress isn't really very minimal. It happens to all of us, so that's something that is in all of our lives. It's just in different levels, and we deal with it in different manners. So if the stress becomes to the point that the patient can't deal with it effectively and positively, then we may see them end up in our care. Physical trauma or illness, specifically head injuries, can cause a psychiatric emergency. I think we're all pretty well aware that drug and alcohol abuse will cause patients to act out in ways that is unexpected or unlike them, or sometimes very dangerous to them or others. And then sometimes we have those patients that simply have a mental illness of some sort that causes them to not be able to control their behavior very well. So we're going to talk about all of these in just a little bit. So behavior is a manner in which a person acts or performs. Okay, right out of the dictionary. An emergency, a behavioral emergency, is any situation in which the patient is acting unacceptable or is not able to be tolerated by the patient themselves, the family, or the community. Sometimes you're going to have the patient that actually calls on themselves and says, that they're afraid they're going to take their life, or they know they're not acting right and they're afraid. And it's not always other people that are reporting this. So behavioral patients oftentimes are confused. They have an altered mental status, but oftentimes they deal with this emergency in very different ways. They can become very reclusive, they can become very combative, they can become very, very aggressive. And this is kind of what presents the challenge to us, is to figure out the best way to, number one, stay safe, and B, handle this situation to do the most good for the most people. So some psychiatric conditions that we deal with on a frequent basis are anxiety and panic disorders. Oftentimes we have people that are having panic attacks. If they're having an anxiety attack, it sometimes presents as chest pain. And so these patients are going to present to us as more of a medical patient than a psych patient. And is there any way in the field to absolutely rule that out? At the EMT level, no, there is not. At the advanced level, maybe, but not completely. But oftentimes these people have a history of anxiety or panic attacks, so that helps to get that from them. Depression is huge. We see a lot of depression, and I have my own theories on why we're seeing more and more depression, which thankfully to you, I won't be sharing all of those with you tonight. Some other big things that we see that are kind of disturbing, sad, it makes me feel very helpless, and that's for those patients with bipolar disorders and schizophrenia. Those are very severe mental disorders that unfortunately the patient will live with throughout their life, and can, to some degree, be controlled by medications, but the medications for both of those disorders are pretty drastic and have some very serious side effects themselves. So, very kind of a sad situation there. So, causes of an altered mental status, and these are things that we can check and should check in our patients every time we have someone with an altered mental status. Number 1 and 2 kind of almost go together, is check a blood glucose level. So if you have the ability to check a blood glucose and check their sugars and see if they're in the normal range, please do so. Otherwise, if they're acting hypoglycemic, like they maybe have a low blood sugar and they're able to maintain their airway, give them something to eat. Give them a sugary treat, some chocolate, a candy, a Coke, or any type of sugared beverage, and see if that helps. The other thing we need to check is oxygen. If they are hypoxic, they are going to have an altered mental status. That is something that we can and should fix immediately. So we want to check and make sure they're being oxygenated. We also want to think about a stroke. And stroke and low blood sugar mimic each other very closely. So if you're thinking one, always check the other. Strokes produce very frequently inadequate blood flow to the brain, and that's why they have that altered mental status. I'm sorry I have the hiccups tonight. So we want to think about a stroke, and we know the ways to test for strokes. We have that Cincinnati pre-hospital stroke scale. There's a men's stroke exam that we can do. So there are tests that we can do for stroke. Other things would be head trauma. And this is probably going to be in their histories where you're going to find this. Oftentimes, an altered mental status will happen hours or sometimes even days after a head injury. And we haven't got to trauma yet, but if they've had a head injury and they have a very slow bleed in their brain, the pressure will build up over time, and as that pressure gets to a certain point, will start to cause an altered mental status. So again, with all of your patients, getting that good history is going to be paramount in doing a good treatment plan. Mind-altering substances. There are more of them out there than I can name, and they come up with brand new ones every day. So this is kind of an ongoing learning for us. Now, when we get to that point, we talk about this a little more. We'll talk some more about those. But then environmental temperature changes. So that's going to be with your heat emergencies as we move into the summer, as well as your cold emergencies in the wintertime. So reactions to stress, your normal reactions are patients sometimes become very fearful when they become under stress. And I'm sure all of us can relate back to a time when we were under a ton of stress. Our mind tends to go to worst case scenario. I don't know why we are created that way, but all of us do that. Instead of thinking about, best possible case, or how's this going to play out, or how we always go to the worst case scenario, which creates more fear and then kind of snowballs on us. Sometimes with stress, we get into a grief mode. And grief mode, you see this with patients that have lost a loved one very frequently. They can't seem to pull themselves out of that, especially if it was someone close, like a parent with a tragic death, or a spouse, or a child. Losing a child is extremely hard. So we see that grief. And as you know, those 5 stages of dying, or the 5 stages of grief and dying, anger plays into that also. And so sometimes you'll find patients that are dealing with a stressful situation become very angry. Oftentimes patients that feel out of control, when they can't control the situation and it's frightening for them, they become angry because they've lost control and they don't know how to get it back. So with our behavioral emergency patients, this is not a load and go situation. And it may be a situation that you may need to have another squad or another service cover your calls for a period of time so that you can spend some time with these patients. If you rush them, you're frequently going to get a very bad outcome. So always tell your patient, now you're trying to build a rapport with these patients. Sometimes that works, and sometimes you can build that relationship. Sometimes you cannot, and you can't take this personally, because sometimes they're just not able to get outside of themselves to even think about a relationship with anyone else. But some things that we can do to try would be to tell them that you're there to help. Look them in the eye, be very soft-spoken, be compassionate, and be honest with them. They will nail you to the wall if you lie to them. So be honest. But tell them that you're there to help. If you remain calm, you stand a chance of defusing an out-of-control situation. If your emotions get out of whack and you begin yelling or demanding, or your voice comes up a notch or two, you will only make the situation worse. Now, in these situations, we need to remain in control, but it has to be done in a controlled and calm manner. So listen to your patient and let them know you're listening. Repeat stuff back to them. We don't want to barrage them with questions because they become frustrated. But you can say, okay, like say you're talking with the patient and he tells you that he's angry about something. We can repeat that back to him. Okay, I understand you're angry. And we're not condoning it, but we're letting them know that we heard what they said. So listen to them, give them their space. We'll probably talk about that here in just a little bit more. But be honest, be calm, and be compassionate. Okay? And then watch for changes in their behavior. Some of these patients can turn on a dime, and we want to make sure that we don't get caught off guard. Okay. So an acute psychosis, acute meaning sudden onset, comes from cognitive disorders such as schizophrenia. And if you've been around a schizophrenic patient, you'll understand this, but they can go from literally being one person to a next very quickly. They can go from being calm to angry. They can go from being someone that you can have a conversation with to someone who's suddenly screaming and yelling at you, and nothing has changed. It's just a change in their mind that's caused this. So it's a breakdown in their ability to process information and react to their environment. Their environment inside their world is very real to them. It isn't to us, so it makes it a little hard to relate, but if we can keep in mind that it is real to them, it will go a long way towards us building a relationship. So some symptoms of an acute psychosis would be hallucinations, seeing things that are not there. Delusions are having, let's see, hold on here just 1 second, having a malfunction. Okay, sorry, got that fixed. So hallucinations are seeing things that aren't actually there. Delusions are ideas or thoughts that really aren't rooted in reality. So they may be under the impression that the FBI is tapping their phones or that they're being watched by people. Catatonia is the inability to move appropriately. Now, I don't know if I actually have this or not, but frequently in my dreams, if people are chasing me, I can't run. I can't move my arms and legs. That's a type of catatonia, if it would happen into real life. So where they become kind of paralyzed with fear, or just their psychic issues take so much control over their body that it actually interferes with their nervous impulses, telling the body to move in a certain manner interferes with that. And then sometimes we see patients with a thought disorder, and we're going to recognize this by them talking, and they're going to be talking in sentences and with thoughts that are very random. They don't make sense. They're not relative to anything that's going on, and oftentimes these patients kind of rant and go off on little tangents that are disconnected to everything. So our big concern is to ensure the safety of, number one, ourselves. Number two, our partners and our team members. Number three is our patient. So we can't help them if we get hurt ourselves. There's a very high risk of you getting hurt in a behavioral emergency. So watch out for one another. So let's talk about how we're going to care for these patients. You're going to see a range of presentations. You're going to see patients that are withdrawn, won't talk to you, won't look at you, nothing. You're going to see these more with sometimes our psychiatric emergencies, but a lot of depression and suicide, you'll see this behavior. You're going to see patients that are talkative, that won't shut up. They just keep talking. You can't get a word in edgewise. They don't hear anything you say. These patients oftentimes become very agitated if you ask a lot of questions. Sometimes they're agitated already. So with these patients, we don't want to ask any more questions than we can, but we do want to offer to help. And if we can get across to them that we want to help them, that will be a very positive thing for both of us. Sometimes we see bizarre and very threatening behavior. And sometimes we see patients that want to harm themselves, or sometimes we see patients that are homicidal, so they can be suicidal or homicidal. Both of them involve taking a life. Suicidal is probably a little less dangerous for us. Not saying it's not dangerous, but a little less so, because their intent is to harm themselves. Homicidal patients are very dangerous, and if they are to the point that they're going to express a desire to harm or kill someone, we probably ought to not be there, and certainly not be there by ourselves. So, key things when we're dealing with this patient is to identify ourselves. Let them know that we're there to help. We are only there to help. We're not law enforcement. We're not going to arrest them. They're not in trouble, but we're there to help. So we want to speak slowly. We want to speak clearly. And we want to make eye contact with them. And this is all just building trust, building a rapport. We also want to listen to them. We don't want to be judgmental, so we're not going to use things like retarded and crazy and out of your mind. We're going to be very careful of how we speak to them. I had a paramedic student just this last week that did some time up in the psychiatric unit at one of the hospitals that they're required to do for their paramedic training. And he took it upon himself to go interview some of these patients and say, did you have any interaction with paramedics ever? And almost all of them had. And he asked them, what could we do as a paramedic to help you next time you get in a crisis? And every single one of them said to be kind and to be compassionate and don't treat me like I'm dirt. So I think there's something to be said for that. So we want to use positive body language. So things that we may do when we get in an uncomfortable situation that we don't realize we do, such as folding our arms in front of our chest, or standing with your hands on your hips, don't exuberate a positive image. It makes us look guarded and defensive and judgmental. So make sure that you have your hands down at your side, and that you are presenting yourself in a manner that your body says, I'm here to help, as much as your words do. So use that positive body language. If your patient is not posing a threat to you, get down to their eye level. Okay? Now we want to stay in control of this situation, and we need our patient to kind of recognize that we are in control, and because of that, we can help. If we let them get in control, we're in a world of hurt. Okay? So acknowledge their feelings. If you've got a patient that's hallucinating and seeing things, don't play into their hallucinations. So you can acknowledge, I understand that you see things. I'm not seeing them, but I'm not saying you don't. Okay, but we don't want to say, oh yeah, I saw it, and play right into that, because they may very well know. They've maybe down this path maybe several times before, and they know that the things that they're seeing aren't really real. And if you play into that, they're going to call you on it. So for most people, our personal space is 3 to 4 feet. And if you're standing talking to someone that you don't know, that 3-foot space is very comfortable. You can stand that close, talk to someone. If you want to try and experience something, just talk with someone and then just take a step forward, about a foot into their personal space. So instead of being 3 feet apart, you're 2 feet apart. You're still not touching, but you're closer. You'll see they back up. And that's for people that you're only like acquaintances with. Obviously someone that you're intimate with or very close to, that space is smaller. But for these patients, this slide says stay at least 3 feet from patients. You are going to have some patients that 15 feet is as close as you're going to get to them before they freak out. So understand their personal space is going to be much, much larger than it would be on a normal person. So watch them for their body language, and watch as you're approaching. There will be a definite line. When you get too close, you're going to get a reaction from them. If you take a step back, they'll calm back down. And our goal is not to agitate them, so respect to those boundaries and figure out where that line is and then honor that. So watch for an emotional status change on these people. As we talked about before, they can change. And be prepared to restrain these individuals if they become a threat to themselves or to you. We try and do soft restraints with EMS, but I would encourage you, if you are on a behavioral call, you probably ought to have law enforcement on scene. If this gets ugly, they're better trained at restraining people and are capable of doing it more so than we are. Plus, there's a great legal area in there, so we want to stay as on the side of the law as we can, and having law enforcement there will only help us do that. So if we're going to interact with our patient, okay, we need to plan our approach in advance. Okay? So we want to stay, now this, it looks like they're ganging up on him, and they probably are, to try and take him down. But if you decide that you're going to restrain a patient, I wouldn't do this just to talk to them, get all around, but what you might do is, I'm going to talk to the patient, and I'm going to have a couple of my partners get in a position where they could gain control of the situation if they need to. I do not ever want to have my patient between me and the way out of the room. Nor do I want that situation to be for any of my partners. So sometimes flanking your patient puts you in harm's way. So if you're going to get behind your patient and you're in an enclosed area and cannot get out, should he turn on you, don't go there. It's not worth it. But if you're going to take them down, if you decide that you need to tackle and physically restrain them, we want at least 4 people. You can see here you've got, they've done some coordination, and we've got 1 person for each limb. So each person knows specifically what limb they are going to try and restrain and act on. If you've got a 5th person, have that 5th person control the head. And make sure that you don't get bitten. These patients will bite, they will bite, and they will spit. So spitting isn't horrible, and it can be washed off and cleaned up. Biting can cause some pretty severe problems, so watch carefully. So get your scene size up. This is really important with these patients, is that scene size up and calling additional resources. You want to have enough manpower, and you want to have law enforcement there. We want to complete our primary assessment. So if our patients are talking to us and yelling at us, we know they have an airway, we know it's patent, we know they have a pulse. And that can all be done at a distance on these type of patients. So what we need to find out is their airway adequate? Are they hypoxic or not? Are they bleeding, and are they hurt? So we're going to do as much as we can without irritating the situation. We're going to try and gather a history if we can. With some of our patients, you might get a history. With some of our patients, you won't know if what you're getting is going to be something that you can trust or not. Sometimes you have family members there that can help. Sometimes you don't. So this is really going to be up in the air how much you'll get, but do the very best you can. So some things that we might see is we're going to look at how our patient presents. Are they all disheveled and their clothes a mess and they look very unkept? If they do, look at them, and do they look like they live like this normally? Are they dressed like a homeless person? Is this their normal? Or do they have dress clothes on and they maybe are dressed like a business person, except their shirt's off and they're wandering down through the highway with dress shoes on, dress slacks off, their hair's all a mess? I mean, that puzzle doesn't fit together. So look and see, and this will tell you a little bit of maybe how long this has been going on. If they're dirty and unkept and their clothes are a mess and they're kind of homeless, this might be a chronic ongoing thing for them. But if it looks like they just came out of the office and now they're doing all this weird stuff, this maybe is more acute. That was more of a sudden onset. Look at their hygiene. That will also tell you if they're smelly, sweaty. They maybe have been doing this for a while. If they're still relatively clean and their hygiene is good, again, maybe this is a sudden onset. So we're going to look for unusual activity. We're going to look for their agitation levels. We're going to watch for unusual speech patterns. This can be slurring of their speech. This could be inappropriate speech. It could be talking that makes no sense at all. And sometimes you'll get what we call alphabet soup, that they're saying words, but they're not really all words, and they make no sense whatsoever. Or word soup, we call that a lot of times, not alphabet soup. And I can't tell you what you're going to see most often, because these all have their own individual case. Sometimes we see bizarre behavior, where they're fighting things that aren't there, they're seeing things that aren't there, they're imagining things, they don't know who you are, they think you're somebody that you're not, they're not recognizing people that they should recognize. They may have bizarre thoughts like, that they're a pirate, or they have a sword and they're going to stab people, or weird stuff. Suicidal and self-destructive behavior. Sometimes people are very honest and tell you that I really want to kill myself. A good question that I always ask is, do you have a plan to do that? If they don't have a plan yet, that lessens my sense of urgency. It doesn't go away by any means, but it lessens it. But if I have a suicidal patient who has a plan on how he's going to do it, I'm going to take very serious note of that. And I want to find out what his plan is. And oftentimes they're willing to talk to you about this. This is a reality to them. They have thought long and hard about it, and they've come to grips with it. They're not embarrassed. They're not ashamed. They know it's probably not normal, but it is what it is at that point. And if they've got to the point they have a plan and they're going to kill themselves, they have nothing to lose. They don't really need to hide that from you. What we do have to watch out is the very aggressive behavior if it's towards us or someone else. So with our patient care, again, it starts with us. Take care of number one. We're going to make sure our scene always stays safe, constantly reevaluating. If we can get to our patient and treat any life-threatening problems, we will. We want to consider the cause. Could this be a medical or a trauma-related injury that's causing this behavior? And that's going to be probably from your scene, as much as you can gather from your patient presentation, and from anybody else that may know something, people on scene, family members, bystanders, things like that. So we're going to encourage our patient to talk and tell us how he feels. Most of this stems from emotion, and so let's get those emotions on the table and let's talk about them. Like I say, never ever play into a hallucination. You can certainly recognize that they understand, that they're seeing it. That helps them to recognize that you're trying to understand, and that's a good thing. But don't ever agree that you see something that you don't. And then, if you've got family members there and the patient's okay with them, maybe use them. Sometimes you have family members there and the patients are very angry at those family members. In that case, it's probably better to remove them a little from the scene, get some information from them as you can, but try not to make that situation escalate any farther. So suicide is the 8th leading cause of death currently. This is very sad, that it is the 3rd leading cause in the age group from 15 to 24 years old. And it breaks my heart to think that our society has come to the point that, our 15, 16, 18-year-olds should be dying from motorcycle crashes and diving accidents and things that they do because they're having fun and enjoying life and just being a little bit irresponsible. Really shouldn't be coming from suicide. So we're seeing our suicide rates have always been fairly high in our older adult population. And, as people get older and they lose a spouse or they become diagnosed with a terminal disease and they're faced with living out their years being a burden to someone they love or a burden to society or living in pain, sometimes that becomes more than they can bear. Or, if they've lost their friends, their spouse, and they're kind of alone, suicide becomes an option for them. So just keep an eye out in those 2 age ranges. It's not to say it's not going to happen otherwise, because it will. But we don't typically think that our older adults are suicidal. We do see it a lot more than you think. So our potential or attempted suicides, we have to always take those seriously. I was called to a call one time, and I had a gal that had taken one of the little flip tabs off a pop can and rubbed it on her wrist and said she was trying to commit suicide. When we first got there, it was kind of laughable because she had really no more than some scratches on her wrist. But we had to take her seriously. A few years later, she did actually have a very serious and nearly successful attempt at committing suicide. So the thought was there. I think she just wasn't brave enough to follow through with anything. But as her depression and anxieties increased, she did develop a plan that almost worked. So keep it in mind, even when it looks like kind of a silly cry for attention. Sometimes it's just that. It's a cry for attention, for help. So we're looking for depression, people with high stress levels, a recent emotional trauma, maybe the death of someone, loss of a job, could be something as a DWI, and they're losing their drivers, or OWI, whatever we call those in the state, losing their driver's license. Maybe, in our kids, a girlfriend broke up with them. There has been more teen suicides over the breakup of a relationship, which, as us older adults look at it, it's like, heck, that's nothing. You're going to have 25 of those before you're done. It's traumatic and life-changing when you're a teenager. So emotional trauma can be all different levels. And again, we talked about those age ranges that are high. Another thing that plays into suicide is drug and alcohol abuse. Sometimes they get down into that, and there just does not seem to be a way out. They know that they're hurting people around them, and they can't imagine life without their drugs and alcohol, and they can't imagine living with it, so the alternative is suicide. Other things we want to think about, if they're threatening suicide, we got to take that, we've got to take charge and do something there. Again, we talk about asking them if they have a plan. Other things we want to consider is, have they had previous attempts? And ask them that. Most of the time they will tell you if they've tried before, and if so, how. A big trigger for these guys is if they're very depressed, and now all of a sudden they're not. And it's out of character for them. Oftentimes what that means is they've come up with a plan. They don't have to live this way anymore, and they're okay with that. So they kind of come to grips with this suicide thing, and their depression lifts, the black cloud lifts, because they know that what they have to do is only a temporary until they can implement their plan. So that's pretty serious. Although it looks like a positive sign, sometimes that can be an indication that we've got a patient that's much closer to suicide than he was earlier. So our personal interaction, don't threaten, don't argue with these people. You're not going to win. So don't try, don't go there. We don't want to indicate that we're going to use force, so don't threaten them that you're going to use force. If you decide that you need to, then just do it. Don't threaten, you're only going to escalate the situation. So, scene safety, look at for life-threatening problems, reassess frequently, and let your receiving facility know what's coming. They're not going to be probably any better prepared to handle this patient than you are in the back of your ambulance without some help. Especially if you're going to a smaller hospital. They're going to want to get security there. They're going to want to get some extra hands in case they need to restrain these patients. They also need to get them put in a place where they're not going to be a danger to the other patients. So they'll want to prepare a place for this patient where he can be safe and secluded. If it's a hospital that has a psychiatric facility in it, they may want to pull some help down and get some psychiatric help there in the hospital, so that when you roll in, they can start that assessment and get them the help they need much quicker. So clues we're going to get are from dispatch. Oftentimes with dispatch, we get dispatched out to a patient not acting appropriately, patients that are hallucinating, seeing things, being aggressive and violent, yelling, that type of thing. So we're going to get information from our scene, from our family, our bystanders. We're going to look at our patient and how he is positioning himself. Are they fetal position? Are they curled up on the couch? Are they secluded in a room? Are they standing with their hands on their hips? Do they have their feet spread apart, and do they have a stance looking like they're maybe ready to take you on or to defend themselves? And figure out, where are they in a room and where can I be that's going to be safe and I have a way out. So make sure that your route's always open. If they try and come around and flank you, it's time to get the heck out. Okay, there's a time to walk away from this. And always watch for weapons. They can pull a weapon out of their pocket, their waistband, their coat, very, very quickly. So if you see that happen and you can get away safely, get away. If you have to defend yourself because you can't get away, then you need to maybe practice those maneuvers. And with that, I would contact your local PD and say, can you give us a quick debriefing on how to handle ourselves if a patient would pull a gun on us? We can spend some time in class talking about that, but law enforcement's kind of the expert on that. So it also is going to build a good relationship between you and law enforcement if you can rely on them for a little training and they know they can do the same. So watch for those weapons, whether it be a knife, an ice pick, a gun, a broken bottle. It's amazing. Homeless people, if you're in a situation where you may be interacting with those, are almost 100% always armed because they live in defense mode all the time. So be extra careful with those patients, knowing that. Okay. So ensure your safety and theirs. We're going to calm the patient. We're going to perform a thorough assessment if we can. Now understand, you probably are not going to be able to do this on most patients. We want to be prepared to restrain them if necessary. So we've talked about a lot of this already. Additional help. That may be another squad. It certainly should be law enforcement. If you've got a situation that you've got somebody out of control, they're trained, they're prepared, they know the laws, they know how to help you stay within the laws and be able to control that patient. And they have handcuffs. They come already built with restraints, and they know how to use them. If you have a situation you're not sure how to handle it, it's okay to back out and call medical control and get some advice. Okay. Well, watch for those sudden changes in behavior and reassess very frequently. So reasonable force is only necessary if it's going to keep the patient from hurting themselves or others. So we kind of call that reasonable force, and that's going to be changed with every patient. If you've got a corn-fed Iowa boy and he's weighing in about 310 and he's 6'3", he's going to take more force than your 5'2", 120-pound young lady that's all strung out on drugs. It's just reasonable. So we're going to look at size of our patient. We're going to look at how aggressive they are. If they're very aggressive, very combative, if they're completely disassociated with reality, they're probably going to take more force. Some drugs and some substances will override anything we can give them. Now I'm going to post, or I actually have posted on your course page, a little video on excited delirium. It's a 10-minute video. I'd encourage you to watch it so you can see how strong this young man is. I'm going to post a couple more on bath salts so you can see how erratic these patients that are on drugs, bath salts being one of the newer drugs that's out there, it causes the patient's body temperatures to rise tremendously. They may have used it several times before and had a good high, and then for whatever reason, we'll try it an additional time, and it will literally cause their body temperatures to raise, and it cooks their brain. But we don't have enough sedatives in the back of our ambulance or probably in our ER to sedate these patients because that drug is so strong it overrides everything. These patients are really hard to restrain and take down. So those patients are going to require a lot more force, and there's going to be a much higher risk of them being seriously hurt as well as us. So look at that behavior. Those patients, particularly bath salts patients, are pretty content. They're usually sweaty and they're usually naked because their body temperatures are so high. And just left alone to wander in their little world, they're usually fine. But oftentimes they wander into traffic, or they wander into businesses, and being naked sometimes causes a problem. And so frequently we have to contain them for the safety of themselves and others. And once you try and contain them, they go ballistic. And I've seen them, I haven't seen it personally, but I've seen in videos where one guy literally punched his way through with his fist through a center block wall and crawled through the hole and got away. I've seen him rip boards off of fences and crawl through and get away. They're amazingly strong, and they're hard to hang on to because they're so stinking sweaty. So we're going to have everything from that down to our people that are depressed and kind of reclusive, and you have to be prepared for any of that. So look at your policies and your protocols that your department uses for restraints. You may have soft restraints, which are cloth that you can tie around their arms and ankles, or their wrists and ankles, and restrain them to the cot. Some Some agencies use duct tape, which works very well as long as you don't get it so tight you cut off circulation. If you've got law enforcement there, they have handcuffs. If you let them do that, then the responsibility is on them, and all you're going to be responsible for then will be just making sure that circulation is maintained. But don't jump in and restrain a patient without knowing what your legal parameters are and what your protocols and laws in your area will support. So excited delirium, we talked about this just a little bit about, and again I posted a video so you can watch this, a particular case on this. It's an extremely agitated, so they've got a psychosis of some type going on, and they're not thinking clearly, but they become extremely agitated. Sometimes this can cause cardiac arrest. It can cause their heart to stop, depending on the cause of the excited delirium. They're not generally coherent to be able to understand the gravity of the situation or even respond to your commands most of the time. Cocaine is another big factor. Bath salts, like I say, is a huge proponent of this excited delirium. I don't know if you remember in the news a few years ago in Florida, there was a black gentleman that was caught. He was naked and he was eating the face of a homeless man, and it was very graphic. The police actually had to shoot him to get him to stop, and he ate a good portion of this homeless man's face off. I think the homeless man did survive, but it is strongly believed that the gentleman that did that horrible thing was high on bath salts. Unfortunately, there's no drug test for bath salts, so that will never be confirmed, but we see that type of erratic behavior with patients that have taken that particular drug. So when you watch that excited delirium video, in the process of trying to restrain him, they actually occlude his airway, and it's called positional asphyxia. They are trying to restrain him. One of the officers puts his knee in the middle of this gentleman's back and actually causes him to stop breathing and suffocates him for the most part. That is very easy to do because you become so, your strength at holding this person down has to become greatly increased, and so you're working so hard to maintain control that you end up harming this patient. Oftentimes these patients end up face down because you're trying to restrain them, you're trying to keep from getting bit, you're trying to keep from getting hit, so face down makes the most sense. Unfortunately, that puts their airway at great risk. So always, 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 if you're going to restrain them, get them sitting up as quickly as you can to protect their airway. So have adequate help. Make your plan in advance. Decide who's going to do what. Have a key word. So when I say taco, we're all moving in. So it happens quick and in a planned manner, and we can get this patient down so that he doesn't really have a time to react and hurt himself or us in the process. So we're kind of doing this distract and then attack type thing. So if I'm the EMT that's talking, I'm going to be trying to keep his attention on me by asking questions, doing movements, creating a distraction so that my other 4 team members can get around one at each limb and then take him down, grabbing the limbs, making sure that we don't bang his head. This is saying use leather restraints in the supine position always. Supine being that he's laying on his back, not his face. The leather restraints are going to be subjective to what you have and what your protocols indicate. Leather restraints aren't nearly as damaging as metal, so handcuffs can definitely damage them. Leather's going to be a little less damaging, but they do make some nice cloth restraints that sometimes are effective. But always in that supine position. You want to make sure you don't ever put them face down. So you're responsible for his airway. You're responsible for that throughout the transport. If your patient is spinning on you, it is appropriate to put a mask on their face. If you've got their hands restrained, they won't be able to work that mask off too easily. Some agencies have like a netted mask that you could, it's a hood that goes over their head. It's made out of netting, so they can breathe, they can see, but they can't spit through it. So if you have one of those spit hoods, that's appropriate to put on them too, as long as their airway is not compromised by that. And document the heck out of this. Everything you do and the reason you're doing it needs to be documented. Very good chance this one might go to court, so cover your rear ends on that one. Choose your correct facility. If you've got a facility that has a psych ward, that would be the place I would take them. If not, I would get on the phone and find out where they want this patient. These are kind of hard to find a home for them because there's very few mental facilities in the United States, especially in the Midwest anymore. And the beds are almost always full because we have such a high mental illness population. So sometimes it becomes difficult to find a home for them, and you may find yourself transporting these patients from hospital to hospital to get them into a treatment plan. So our consents that we're going to worry about, if we've got a patient that has an altered mental status, they cannot sign a release. So they're going to have to go with you or with law enforcement against their will, especially if they're a danger to themselves or others. It is illegal to commit suicide. So if someone in the state of Iowa threatens suicide, by law they have to have a psychiatric evaluation. And that can happen by voluntary or involuntary process. But they need to be evaluated by someone that's certified to do that. So if you're really not sure, contact your medical director and get law enforcement involved. You're not going to hurt yourself either way. Sometimes EMS providers are accused of sexual misconduct. So if you have a young female and you're going to be restraining that patient, it would be very appropriate to have a female EMT in the back if you have that option. If you don't have that option, I would see about taking someone with me in the back. Law enforcement, a family member, a fireman, someone that would agree to ride with you so that it's not your word against hers. Some ambulances are starting to become equipped with camcorders in the back so that you can record what's going on back there. This would be an appropriate time, if you have that option, to use it, so that if there's ever an accusation made, you have got some validation of your behavior. Okay? And that's all I have. I hope this helps. Do watch those 2 videos that I'm going to post for you, and let us know if you have any questions at all. Happy learning!